Our next speaker is Jerry Schreimer, and he's the Chief Operating Officer and Chief of EMS in Saskatoon. During his extensive career, he's been a supervisor, educator, public relations coordinator, director of operations, and last year he took up oversight of 2 services in Alberta, in addition to Saskatchewan. I notice also that he has been awarded the Governor-General's Exemplary Service Medal, the Saskatchewan Protective Services Medal, and the Saskatchewan Millennium Medal. But even more interesting than that, you've been called away on emergency service situations overseas in 1988 in the Armenian earthquake, and in the 2004 Asian tsunami in Banda Aceh. Now, I was in Banda Aceh with World Vision for a period of time, so it might just have been we were in the, I remember seeing you there, amongst the thousands of others. Okay, Jerry is going to talk to us about, here we are, Better Together Collaborate, no, that's our conference theme. Sorry, I had the notes here, I'm a bit badly organised at the moment. Look in your program. But it's on the theme of collaboration. So my apologies, Jerry, in not having the title with me. I had it down there. Would you please welcome Jerry Schreimer?
All right, good afternoon. Morning if you're in Saskatoon time, so it's about 1 a.m. on Wednesday morning, so I'm getting used to your time zone just in time to head home shortly. So I'm currently the Chief Operating Officer and working for Medavie Health Services. So I'm responsible for our Western Canada operations. So I want to give you a little bit of a corporate overview about Medavie Health Services, talk about our community paramedicine experience, and a little bit about the primary healthcare vision that Medavie sees. So Medavie Inc. is the top tier, and Medavie Blue Cross is one arm and Medavie Health Services the other. And we only have one true stakeholder, and that's Medavie Health Foundation. So even though Medavie is a for-profit company, all the profits go to Medavie Health Foundation, which is a non-for-profit. So what I found really interesting when the service I currently work for was bought by Medavie, you look at insurance, and insurance is all about risk. And you kind of wonder, why did you get into ambulance services and paramedics? Because we're nothing but a big risk factor for everybody. So it talks a little bit about what we do, but what's really interesting is when our profits go to the Health Foundation, they have 3 main arms, and that's child and youth mental health, and that's what they support. They support type 2 diabetes, and just recently they brought on PTSD as one of the arms that they support. So all the profits go to programs across Canada that support these 3 visions. So the insurance side covers 2.9 million people. We have 5,500 practitioners. We provide services to about 2.4 million people. We're operating in 8 provinces, and we respond to over 350,000 requests for services. So we provide health services benefits management on the insurance side, obviously EMS response and 911 public safety, so we operate call centers. We do clinical training through the health ed program out of Halifax. They do primary care paramedic programs and advanced care paramedic programs. Primary health, and that's really becoming very big in New Brunswick. There's a new program happening there. And we also run telehealth through 811 in Nova Scotia. So that's been a new acquirement that occurred this year. So again, EMS is obviously, that's our roots, that's where we came from. But we're also very experienced in tailoring the needs to our client. So part of the big thing we'll get a little bit into is the difference between, we have some managed contracts and we also have ownership. So here if we're looking at the map, and we start on the East Coast, so we have Island EMS. They also run a 911 center there. They provide air support on the helicopter side, obviously road ambulance. EMC in Nova Scotia, same thing, helicopter, 911 call center, and the ambulance side. New Brunswick is very big, and that's where they're really getting into the community paramedicine and what they call the extramural program. The extramural program is going to be marrying the 911 call taking, the 811 side, home care, and the paramedics along with their community paramedicine programs. We have MedCare in Boston, so road ambulance on that side, and also they do a big community paramedicine program there as well. 2 services in Ontario, again, road ambulance, community paramedicine. And what I'm very familiar with is Saskatoon and Alberta. So the Alberta model, because it's a single health authority and Alberta Health Services, they either are a direct delivery or they contract, and we happen to have 2 of those contracts. So we're not really big into the community paramedicine there because our staff that are working there are so busy doing road ambulance. We've offered it up to them that we said, if you have a community paramedic program you want us to do for you, we'll do it at our cost for 3 months, but if you find it's beneficial, then we would like you to buy the services from us. So I'll talk to you a little bit about the Saskatoon program later and how it was bought and the big benefits it's having. So Saskatoon, my home service, I've been there for coming on 39 years now. Road ambulance obviously is the big piece, and community paramedicine is also huge. But what's interesting in our communication center is there's a lot of collaboration that goes on in our communication center. So one of the things that happens is obviously we get the 911 call from the PSAP center, whether it's the Saskatoon Police PSAP Center or the Provincial PSAP Center in Northern Saskatchewan, which if people really want to know more details, I can explain later. But one of the big programs they do is called ACAL. It's the Acute Care Access Line. And this was run by the health authority prior to them contracting us to do that 5 years ago. And what happens is whenever there's a patient in rural Saskatchewan that needs to come into tertiary care, cardiology, neurology, orthopedics, multiple trauma, whatever the situation may be, that call comes from the rural physician into our center, and then our communication staff will find the appropriate specialist to connect the 2 practitioners together. They'll stay on the line, they'll transcribe the conversation, and then after that, the arrangements are made to move the patient into Saskatoon. So the big thing is they find a specialist that's willing to take the patient. Then after that, it goes to the appropriate facility. So since it's come online, I've talked to many physicians, some that are very anti-paramedics, anti-contracted service, and when they said, when we took on ACAL, they have nothing but praise, and they're very happy with the service that's being provided because it's customer service oriented. So as paramedics, that's everything we've always wanted to do, right? Yes, we save lives, but a lot of it is it's customer service. It's taking care of those patients and the patients' families' needs. So on the communication side as well, MD Ambulance, our communication center in Saskatoon has been accredited 6th consecutive time. The only communication center in the world that has gone through that accreditation 6 consecutive times with medical priority dispatch. So community paramedicine, I will touch briefly on some of them. If there's a program that you're interested in, you want more details, come see me and I'll get you in contact with the lead provider from that service within the Medivie Health Service groups of companies. So a lot of our programs, and we leverage EMS resources to add the value. So when I look at what's happening in New Brunswick, and we'll take an example, you have an ambulance service in rural New Brunswick, but you have a home care patient in that jurisdiction, but you don't have a home care nurse in that jurisdiction. So previously, she would travel an hour, hour and a half by car, spend 15 minutes, 30 minutes with that patient, and then head out to another client. So we're saying, well, that makes not a whole lot of sense. When we have practitioners, paramedic practitioners that can do that home care service with collaboration with that nurse, and we're saving a huge amount of travel time. And one of the things that the government in New Brunswick asked us, they said, we'll give you the same amount of budget that we use now, but we need you to increase the amount of patients you see. So that's what's ongoing now. They're that close to announcing that document with the province of New Brunswick, but as those of you that work with politicians, they're waiting for the right moment, so it's going to leverage their ability to get reelected. So some of the programs, Long and Briar, that's in Nova Scotia. That was one of the very first community paramedic programs where very sparse population, but very hard to access. can't get physicians, difficult to get practitioners. So what they did is they paired up with nurse practitioners and paramedics, and they now see the majority of those patients that are Longbrier that need to be seen. It's reduced, as you see, the ED visits to the nearest hospital, 23%. And a lot of these programs, to make you aware, a lot of the practitioners, that's not all they do. Typically, that's part of their rotation because there's not too many practitioners that just want to do community paramedicine full time. They still need their adrenaline rush. They still need to go out and see that trauma or those acute STEMIs and cardiac arrest. They still want to keep up those skills. So a lot of our practitioners rotate into some of these programs. The extended care program, we mirrored ours off in Nova Scotia, and it's happening in Saskatchewan as well. And that program is where we have extended care paramedics who work by themselves, and during the day, they go out to the long-term care facilities. So they're doing things such as rehydration, first dose antibiotics, IV antibiotics. They're doing phlebotomy, obviously 12 leads, things of that nature. And the big piece of that is it is stopping patients going to the ER, so ER diversion, but it's also freeing up beds. We all know that when a patient goes from a nursing home to an ER, they're tying up two beds, the nursing home bed and the ER bed, or the hospital bed, because on average, the seniors that are getting transported because they have the core issues up to 3 minimum, they're admitted for at least 7 days. So this costing of this program was figured to be, if we saw 3 patients in a 12-hour shift, the program broke even. So we're seeing between 5 and 7. The first year of the program, we saved the system $1 million. Now, I haven't seen that account where it says there's $1 million sitting there, but we know they've been able to redirect that funds to other programs. Ontario's doing a lot of community paramedic programs, and one of them is they're taking their very high users and they've used a very sophisticated software program. And so as soon as a patient hits the 911 system and or their health services number gets entered into registry, the appropriate people on that team get notified and say, hey, Mr. Smith is in the ER, and then it could be social work, it could be addictions, it might be the nurse, it might be the paramedic that are saying, why are you back? What's going on? You know, these are the repeat offenders that usually have social issues that need to be addressed, and they don't need to be addressed in the ER. So that's having a big impact as well. The Mobile Integrated Health Program is the New Brunswick model, so that's going to get going soon, and they're predicting that 63% reduction in the ER visits. And palliative care. So they're talking about palliative care in Nova Scotia and PEI. That's going on. We're also doing it in Saskatchewan, and that's where, again, we're treating palliative care patients at home. So those that want to stay at home are getting treatment at home, whether it's pain control, whether it's IV rehydration, whether it's catheters, whatever the situation may be. So making a huge difference there as well. So this is more specific to the Longbrier, give you a little bit of geography for that area in Nova Scotia. The big piece is the decrease in emergency room visits. The extended care paramedics, again, the ability to be bedside with them after hours, very similar to what was going on in Manchester, UK, where physicians did not want to do home visits anymore. They were running into problems with physicians, losing physicians, things of that nature. So this ability to give them advanced scope of practice, the ability to confer with physicians and other practitioners, makes it immediately noticeable that we have a ER diversion practice in place, and it frees up the time in the ED. So the visit program in Nova Scotia as well, very simple. You got rural EMS providers that aren't doing a lot of patient contact, and this gives them the patient contact aspect of things, prevention, and also post-discharge. Palliative care program, what I spoke about a little bit earlier, nothing, you know, it's not a surprise, right? We've always been wondering why are we taking patients to the ER? And this can be operated under our current scope of practice within their homes as well. We had a patient that was in Saskatoon and is a dementia patient, palliative, needed care, was constantly going to the ER. We all know as soon as you take a dementia patient out of their surroundings, what a terrible structure change that is for them. And then you get them home, and now the family or the care home has to work with them. So we're on a conference call between the practitioners and the physician and the family member. And at the end of the conference call, the son was crying, and he couldn't believe, he says, "You're actually coming to my dad's home to take care of him and do this for us?" And, you know, when I heard this story, I says, well, that's a no-brainer. Like, why didn't we think of this before? Or why wasn't this offered to that family before? So a lot of this isn't real science. This is just, we're now doing the care that we're expected to do, and that we should have been doing long before. Chatham-Kent is the area that's doing that program with the software and the opportunity to take the repeat offenders and get them to the right practitioners. So again, addiction, social work, things of that nature. Talks about the different cohorts and some of the decreases they've seen. So when you see a decrease in ED visits and hospital admissions and hospital bed stays, I know the biggest challenge we have is when we go and ask for new money for a new program, because sometimes administrators and politicians have a hard time spending new money that has not been allocated to decrease costs, and which in turn saves money. I know when I was in Melbourne a couple of years ago, we talked about the referral system and how the referral system, when they asked for more money to increase it, you know, they got the check signed fairly easy because they turn around and they show them the data that turns around and tells them how much they're saving. My boss has always turned around and told me, he says, "In God we trust, everybody else requires data." So I think that's very important that we continue to drive data this way. The U.S. service that we have in Boston, it's an interesting concept with them. They were doing some really high acute patients, so MS patients that are trached or in wheelchairs, and really a lot of work. But a lot of these patients know when something was going on, they could tell you what's going on and what they needed. But before this program came about, you can imagine, especially in the United States and their healthcare system, you get someone who's a very complicated, you know, low quad, gets chest infections, needs antibiotics. Where are they going to put them if they go to the ER? They're going to ICU. So big cost to the system. And what they've done here is they've been able to work very closely with practitioners, and they do it after hours because they have a nurse team that takes care of these patients during the day, but after hours the patient can make contact with the paramedics. They'll go in and they'll give them the antibiotics. They'll start treating. They'll confer with physicians at the hospital, and it's made another huge reduction in ER and ICU visits. Here's some programs I can talk about more in the integration and collaboration because I've been directly involved with them. We have critical care paramedics embedded with our Saskatchewan Area Ambulance Service. That's been since 1993. Saskatchewan Area Ambulance is the longest running government air ambulance system in the world. We know paramedics and nurses have a cross-function of protocols. So it's worked quite well. That program has been very good because it allows practitioner longevity. 3 of my practitioners that are on this would no longer be working EMS just because, I don't want to say they're old, but they're old, and you know, they've got bad knees and they can't lift and things of that nature. So this has extended their career. We have advanced care paramedics that work in the ER. They work in our tertiary center. And this happened probably about 15 years ago when they had a big influx of nurses leaving the ER, and they brought new nurses in, but they didn't have a lot of critical care experience. So the paramedics were brought in to work in the trauma area, where all the multi-traumas go, all the CTAS 1s, patients that need high level of care. And to this day, they still don't want to get rid of the paramedics. So we've cut down our hours. We were 24/7. Now we're only 3 nights a week, but it's also good training ground, and it's free education where our paramedics get paid to learn, and they're taking care of some very high acute patients. And it also frees up nurses when they have acute patients that need to go to MRI or CT. It's the paramedic that goes up with them. Primary care paramedics and collaboration with city police. This is kind of, we help them out, but they're putting a lot of liability on us. So it's unfortunate that we had, our police service was known to have a lot of people die in their detention area. And a lot of it was they have first aid training as far as the officers go there, but they didn't know what to look for, right? A lot of the patients that were again, this is a challenge. We call them patients, they're not patients. They're inmates or they're detainees. the problem is they were being brought in and they were under influence of something. But police didn't know how to assess them to say, are they getting lighter or are they getting deeper? And if they're getting deeper, they need to be transported. So this has helped alleviate some transports as a result of police not understanding what the medical situation was. But it's also worked where we saved, I think, 3 lives to date because we had immediate response with a primary care paramedic taking care of someone that has gone into cardiac arrest, usually because of a drug overdose. That was not picked up initially. So that's 24/7 coverage in the detention area. We have paramedics embedded with the police tactical team. What they do there, they're in the hot zone. They do training with them every month. They learn everything that the police know when it comes to tactical response with the SWAT team. They also get weapons training. They're not given a weapon to carry, but they know how to use it in case they have to treat an officer that's fallen and they become at risk. Then at least they can protect themselves and that officer. We have primary care paramedics that work with nurse practitioners in the community health bus. Community health bus runs 7 days a week, 8 hours a day in different jurisdictions within our urban area. And usually it's a lower social economic area of the city. So people that don't typically go for health care. I know one area that it's on Saturday, and the story about this is it got moved from a weekday to a Saturday because on the weekends the husbands were home from work. And in this Muslim community, they would not allow the wife and the children to go seek health care during the week. So they weren't getting their health care. So they moved it to Saturday when the husbands were home, so the whole family shows up. So they're seeing on average anywhere from 20 to 25 clients per day in these locations. And these are clients that would not normally go seek out health care. So we've caught a lot of issues, hypertension, diabetes, things that would have never been diagnosed before are getting diagnosed now. We talked a little bit about the expanded care role in long-term care. One of the biggest benefits I've seen as a result is we're seeing a lot of calls to these nursing homes that we're going to. And those calls have dropped, and one of the questions I asked, like, are these patients getting better? Like, what's going on here? And what we have found is that the nurses in those nursing homes, after working with paramedics for 6 months, have now had a refresh in their skill level to assess. And now they're feeling more comfortable assessing these patients without having to call the paramedics in. So we're seeing less calls, and the calls we are seeing are higher acuity, but we're still dealing with them at home. So the nice thing about dealing with them at home, we're working with an interdisciplinary team. So the nurse at the nursing home, the most responsible physician is involved, and they're seeing a good amount of care that's happening to these patients, and they're not being admitted to a hospital. One of the new things with palliative care is oncology. So it's only been about a month now that we've been working with the Cancer Center, the Saskatchewan Cancer Center, and dealing with oncology patients at home. So they go in the Cancer Center, they get their chemo, they get their radiation, they go home. Now they have complications, breakthrough pain, nausea, vomiting, dehydration. So now these patients are being treated at home. Paramedics are working within their full scope of practice, but one of the new things that they've gone within their scope of practice is magnesium sulfate. One of the big things these oncology patients needed, and this is also helping decrease these patients going to the ER. One of the problems with oncology patients going to the ER is, one, the ER physicians don't have access to their charts. As a result of them not having access to the charts, they kind of really not knowing which pathway they should go with these patients. So ER is very happy that these clients are being taken care of at home because we're working directly with their oncology physician. A couple other things. We work with our local fire service on continuing education, and we do that on a yearly basis. They come into our house and get educated. We go into their house and do our continuing education with them. One of the reasons why we do this is we have a tiered response agreement. And in that tiered response agreement, depending on the medical priority dispatch configuration, our computer will automatically send it to the fire service. The fire service will then dispatch out a truck, and as soon as that truck is on the air, they switch to a common channel. Now we have total control of that apparatus until that call is clear. And the nice thing is they'll go to the call, they can either downgrade us. There's times we'll send them out to a call because we have no available ambulances. They'll stay on scene until we get there, or they may get there and the family says, oh, the ambulance is going to be an hour. Oh, we'll take mom or dad or whoever it is, and we'll take them by car and we'll go to the ER. My question is always this: if they can go by car now, why didn't they go by car before? different story. One of the last things our advanced care paramedics do, they work in our provincial jail system, and that's on an as-need basis. So typically the health center and the provincial jail system is staffed by nurses, but when they have a shortage of nurses, they'll call on our paramedics. And also Saskatchewan is a big natural resource province, so along with the oil and potash, we have gold and diamonds and things of that nature, but those mines are in the far north, and they're fly-in. So a good example of one of our paramedics was up there, and one of their workers got attacked by a wolf. And through his connections and knowing the EMS system in the province, he was able to rapidly treat this patient, call for a medevac, and got the patient into Saskatoon in a timely fashion. So we're not quite sure that would have happened with a nurse up there, just because she doesn't know the full integration within EMS. So although that's the case, we still don't have a full-time contract there. The mobile health bus that I talked about has won 6 national awards within Canada. One thing that I understand is Manitoba also went to 2 health buses, and they were going to deploy them within rural communities within Manitoba. One thing I don't understand is why health has not taken this on to more jurisdictions within Saskatchewan itself. Gives you an idea on some of the programs that they run there through the nurse practitioner. And I've heard many stories of patients that have had to go to a nurse practitioner because the rural areas have lost physicians, and nothing but positive results with nurse practitioners because they spend more than your typical 7 minutes that you get with a physician. The nurse practitioner needs to spend 30 minutes or an hour with you, they'll do that. So it's been a very positive outcome. Just quickly on primary care, this is nothing new. You know, no matter what jurisdiction you're in, and the people I've talked to, I think the commonality we have with being a Commonwealth country is even though healthcare technically is free, and we know it's not free, that's why our taxes are so high, we face these challenges, right? Whether it's fiscal, the social issues, environmental issues, our demographics, our aging population, things of that nature. So when we go from communicable diseases and doctors and first responders, we look at everything that's going on today, you know, the high integration of 811 and 911 systems, ambulance response, community paramedic response. Mental health is huge, and I don't think it's any bigger than it was before, but we're now starting to accept it. We're starting to accept it as a disease and not a stigma. Disability management is huge as well. So again, one of the biggest problems that we experience is people feel they need to call on paramedics to enter healthcare. And part of it is that doing as a result of our healthcare system not wanting to change. They don't want to turn around and say to Mr. Smith that gets brought in by ambulance or comes in by private vehicle into the ER for some issue that they're going to be waiting in the ER for 6 hours saying, we want you to go to this clinic. So we have to help primary health change their attitude. This is again, talking about the primary health care model and what's happening with 811, so that's the device line, utilizing home care and utilizing ambulance. And I think paramedics and home care need to be integrated, and you know, depending on the situation, making sure the right resources going to the right patient at the right time. Collaboration, I think that's the only way we're going to succeed in delivering health care. With the limited resources that are out there, the practitioners, we all want to do it as long as we make sure that as we provide a scope of practice for our practitioners, that we're not putting them in a world where they're saying, I don't want to do community paramedicine and take care of granny 24/7. I want to share that. I want to do some of that during the day, and then I want to go on the ambulance at the other time, and we find that's a good mix for our staff. So who's going to do this? I like to brag and say Medavie Health Services is doing a great job at trying to push this through. Again, New Brunswick is probably going to be the biggest model for the country. In Canada, we've had other provinces turn around and say, well, we hear you're doing this for New Brunswick, we want to do it, and actually we want to do it before New Brunswick. So I think we're going to see this occur across the country, and hopefully we can have some other jurisdictions copy this as well, because I think it's a good utilization of all the different practitioners, whether it's paramedics and nurses. I know that was fast, but 20 minutes isn't very long.